Khalil sir, you can start, sir.
Good morning and warm greeting to all respected dignitaries, staff members, my supportive colleagues, and dear participants. Good morning to all. I am Mr. Khalil Mohamed Ibrahim, Assistant Professor, St. Joseph College of Engineering, Chennai. First, I welcome our patrons, respected Chairman Dr. B. Babu Manokaran, our Managing Director Mrs. S. Jessipriya, Director Mr. B. Sasisekhar, Principal Dr. Vatti Sesagiri, Dean Research Dr. B. Parvadavartini, and our head of the department and convener Dr. V. N. Nandini Devi. Most importantly, I welcome all the participants for the international webinar on radiation in medicines, diagnostic applications of radiation, organized by Department of Science, St. Joseph College of Engineering, Chennai. Foremost, we thank God Almighty for giving us this opportunity to conduct the event and make it a great success. A few words related to the webinar before commencing session. Radiation has been used to create visual images of the inner body to diagnose the medical conditions. Medical procedures using radiation have saved more thousands of lives through the detection and the treatment of conditions ranging from hypothyroidism to all type of cancer. There are so many conferences, webinar, faculty development program, and workshop happening to enhance the clinical benefits of radiation. This is one such program which is going to enlighten you with the knowledge of radiation application in medicine using imaging tests. Radiations are used to diagnose and treat some medical conditions. We are going to learn how the radiations are used to diagnostics and treat the diseases in this session. With a short note, I would like to call upon Dr. B. Subhas, Assistant Professor, St. Joseph College of Engineering, to introduce our guest of honor of our webinar. Thank you all for the support and participation. Have a great day. Dr. Subhas?
Yes. Thank you, sir. Thank you, sir. Good morning to all the respected dignitaries, staff members, my dear colleagues, and enthusiastic participants. Welcome to the international webinar on radiation in medicine, diagnostic applications of radiation, organized by Department of Science, St. Joseph College of Engineering, Chennai. Radiation can be considered as the transmission of energy through space, treatment of material and products with radiation in order to modify their physical, chemical, and biological properties is known as radiation processing of materials. Radiation processing can be controlled and used for the development of novel material and products with desirable properties. So, radiation in medicine, there are countless areas where the power of radiation and nuclear techniques has been harnessed for the benefit of mankind, not only in medicine, but also in industry, agriculture, and other fields of science and technology. The benefits of patients in terms of lives saved through the improved medical diagnosis and treatment techniques are countless, and well-trained and controlled use of radiation has become a key part of modern medical treatment, especially for certain form of cancer. So today medical imaging helps to detect the diagnosed disease in its earliest stage. So it enables physicians to determine the most appropriate and effective care, where previously exploratory surgery was necessary to discover the cause of symptoms or the nature of disease. So the radiation in medicine is an interdisciplinary science which encompasses the different aspects of the subject, such as nuclear and atomic cross-section measurement analysis, shielding of accelerator, dosimetry, nuclear electronics, radiation physics, etc. It has been increasingly felt that a webinar presenting the subject matter in an integrated manner would be useful to the specialist working in an isolated area of radiation physics as well as to those interested in the global view of their entire subject. In this context, we hope the lecture by our invited speaker, Dr. MC Mahesh, on diagnostic applications of radiation will help the audience to acquire clear pictures in this particular domain. A good introduction is essential to get a speaker off to a good start. So, it is my immense pleasure and privilege to introduce our invited speaker, Dr. MC Mahesh, Professor, Department of Radiation Oncology, Mid-North Coast Cancer Institute of Port Macquarie based Hospital, North South Wales, Australia. Firstly, we would like to thank our accepting our invitation as a speaker for this webinar session in spite of your busy schedule. We are extremely honored to have you with us on this great occasion. Dr. Mahesh has obtained his bachelor degree in the year of 2000 from Mahatma Gandhi College, Kannur. Then master degree in the year of 2002 from Sir Syed College affiliated to Kannur University. Then postgraduate diploma in radiological physics but Baba Atomic Research Center, Mumbai in the year of 2006. He has a great expertise in the field of nuclear physics, radiation physics, diagnostic applications, and radiotherapy for cancer treatment. Moreover, his publications are really inspiring. He has published his research works in IOP Science, Wiley, Springer, Magno, and also publisher with high impact factors. Then he has attended a lot of international conferences and workshops in various countries like USA, Germany, Italy, Netherlands, China, etc. He is the active member of various associations such as Life Member in Associations of Medical Physicists, American Associations of Physicists in Medicine, Corporate Member in IPM, Registered Clinical Scientist, and also the Qualified Medical Physicist in ACPSM. Then he has been invited for lectures in various national and international conferences, symposium, FDPs, refresher courses, and short-term programs. With this brief introduction, I hand over the mic to Speaker Dr. Mahesh. Dear participants, please join us in providing a hearty welcome to our invited speaker of this webinar session. Now I request Dr. Mahesh to carry out the session. Thank you, sir.
Thank you so much. That was a fantastic introduction to this particular webinar. It is proud to be part of this webinar, and I extend my hearty thanks to all the organizers for having me here today to talk about the diagnostic applications of radiation in medicine.
Share your presentation.
I'm pretty sure that, some of my colleagues have, or other experts in this area have talked about the use of radiation in medicine in general, and I'm sure they would have focused more on the therapeutic use of radiation, whereby the use of radiation to treat cancers has been comprehensively covered in the past, I'm sure. So when I agreed to come on this webinar, I was asked to deal with a subject that is slightly different from what has already been discussed. So I thought diagnostic applications of medicine, of radiation and medicine, is a very, very relevant and important area, which is probably equal or more important than the therapeutic application itself is. So without much ado, I will move straight into the presentation. And once again, thank you for having me here today. So today being the 7th of August is a very, very important day in the history of radiation and nuclear science. Something we cannot forget what happened yesterday in history. I'm sure most of you would be very familiar with this particular image. what is on the left is what happened, and what is on the right is what is it today. To be a little bit more clear and specific.
Sorry, sir. Can you share your presentation, sir?
Oh, sorry.
Uh,
Just okay. Yeah, share screen.
yes.
How is that looking?
So not yet.
You able to see it now?
No, sir. Share screen. You need to click that and
Yep.
click share screen. Yeah, fine, sir. No problem.
Okay. Sorry about that.
No, sir. Thank you. Yeah, fine, sir. Now you can proceed, sir.
Okay. Yeah. So as I said, you will probably be very familiar with this particular image that you see on the left in black and white. Is something that happened in 1945, yesterday in history. And to be a little bit more precise, this is what it looks like now. So for people who cannot identify what this was Hiroshima on the 6th of August in 1945, which was one of the biggest use of radiation on humankind that has happened in history. Unfortunately, that was not a peaceful use of radiation. That was the first ever atomic bomb that was exploded just above the skies of Hiroshima and created. Can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
hear
Okay.
you, sir.
Yeah.
You can continue your talk, sir.
Yeah.
So can you press that hide, sir?
What do you want me to do? Sorry.
At the bottom, you have a small.
Oh yeah, you want me to hide that? Yeah. Okay. Cool.
Just hide it. Fine, sir. Hide
Yeah. Okay. So to give a little, I know that I've been given an extremely fantastic introduction here, but just to give you a concept of where I am at the minute, I'm in Australia here in this little town called Port Macquarie, and this is where Sydney is. I'm around 400 kilometers north of Sydney, and my center is called the Mid North Coast Cancer Institute, which consists of 3 centers. One is in Port Macquarie, and then another one in Coffs Harbour, which is around 160 kilometers north of Port Macquarie, and then another one called Lismore, which is around 215 kilometers north of Coffs Harbour. So we've got 3 physical sites under the one cancer center, and we treat all sorts of cancers except for pediatric cases, whereby treatment of children, we do not take care of that. So that is where I work currently, and this is a pretty beautiful coastal town on the east coast of the New South Wales state of Australia. And so when we talk about radiation, as I said before, radiation can be classified into various forms like alpha, beta, gamma. These are some of the very common radiation that we know of. But today, my focus is more on photons, which are electromagnetic radiation. And it is actually the high energy spectrum or the high end of the electromagnetic radiation that is what I am focusing today. And to give a little bit more introduction about how it all started, I'll show you the picture of this great physicist. I'm sure just from the picture, quite a number of people can recognize who this is. This is William Conrad Roentgen, and this is one of the most important pictures that you would see in terms of the development of radiation or the use of radiation in medicine. So today is all about the use of photons in medicine, and this is the hand of Anna Bertha Ludwig. That was the first ever X-ray that was taken in history. And to give an idea about how this happened and whose hand this is, I will go through some of the timelines related to the life of William Conrad Roentgen. To give a brief introduction of his biography, he was born in Germany in 1845 and then graduated with a PhD from the University of Zurich in 1869. And then in 72, he was married to Anna Bertha Ludwig, whose hand you have seen on the 19th of January 1872, he was married. And in 1888, he became the chair of the University of Wurzburg, just off Frankfurt in Germany. In 1893, he became the president of the same university. And in 1895, on the 8th of November, he had a career-changing, life-changing discovery that he did of a new type of radiation called Röntgenstrahlen, which we actually call these days as the X-rays. And in 1895, on the 22nd of December, the first medical X-ray was taken, which is the hand of Anna Bertha Ludwig with their wedding ring on her hand, is the first photo that you have seen in the previous slide. And in 1901, he was awarded with the first ever Nobel Prize in physics. And in 1923, on the 10th of February, Röntgen died from colon cancer. So if you look at the timeline between 1895 and 1923, Röntgen did work with X-rays extensively, and in 23, on the 10th of February, he died from colon cancer. So there is some relationship there from the discovery of X-rays to the death due to cancer, which I think people would have talked to you about the effects of radiation in curing cancer as well as in generating cancer. So radiation can actually create cancer as well as it can treat cancer. So that's a tricky scenario there. And this is me just visiting the University of Wurzburg, where Röntgen worked and discovered X-rays in 2012. I had the opportunity to visit that. Just to give a bit of a personal account, I visited the particular university. I didn't know, when I went there, I didn't know that that was a university where Röntgen did work and discovered X-ray. But it was just the day before I was visiting the university, I had that massive revelation. This is the university building, and this is inside the building with the statue of Röntgen. And these are some of the actual equipment that Röntgen used in this discovery. And from the very look of that device, it gives you a feeling of a early day cathode ray tube. And this is another equipment that he was using. There are all these equipment that Röntgen used in his research work has been exhibited there in the library and in the little museum that they have there. So what happened from that first medical X-ray, which was a Martha's hand, to where did we go? So as I have said before, this was that first X-ray that was taken. You can see the 4 fingers and a high contrast or a high density material that is in there, which is the wedding ring on the hand of Röntgen's wife. And that eventually became the cornerstone for the development of this huge branch of medicine called diagnostic imaging. And then this was the second ever X-ray that was taken, which is probably not that very common. I actually got this picture from the University of Wurzburg's archives. And this was a picture of a rifle, a deer rifle that Röntgen used. And he took this X-ray to see what is inside the rifle, which became the basis of non-destructive testing, the NDT, that we use extensively in the industrial application of radiation. So just the first ever X-ray became the cornerstone of diagnostic imaging, and the second X-ray became the massive, or the beginning of this massive industrial application of radiation called non-destructive testing. So you can see how vivid the use of X-rays are in modern day, and it only started just over 125 years. So from Martha's hand to where? The immediate answer would be that is the birth of this particular branch of medicine called diagnostic imaging. So today I'm dealing actually with that branch, and we will forget about non-destructive testing for the time being. So we will focus on diagnostic imaging. So broadly speaking, use of radiation in medicine can be classified into 3 categories. One is radiation therapy, which is used for treatment of cancer. Then radiodiagnosis, which is the diagnosis of disease. But radiodiagnosis predominantly looks at the anatomical imaging of subjects, which can be patients, or people may not be patients. So it's only after the diagnosis that you can stratify whether they are patients or non-patients. But before that, it is basically looking through the anatomy of the subject that's being scanned or examined. Whereas nuclear medicine is again a diagnostic procedure, but it doesn't really look into the anatomy. Rather, it looks into the physiology or the functional aspect of organs, which is what is dealt with in nuclear medicine, which I will deal with a little bit later. So focus today is on radio diagnosis and nuclear medicine, and we'll forget about the therapeutic use, which is the treatment of cancer, for later. So going through the two fronts of imaging, as I said, anatomical imaging is radio diagnosis and functional imaging is nuclear medicine. So you can see those two pictures. One is the massive mountain Matterhorn, which is in the Swiss Alps. To me, or this is rather from one of my professors in radio diagnosis, who actually showed this analogy, and I should give credit to that person working at the Radiation Medicine Center back in Mumbai. He used to always show this analogy whereby radio diagnosis is more like a mountain, whereas nuclear medicine is like a waterfall, because the mountain is stagnant, and if you look at it, it is stationary, it doesn't move, but you see the greatness of that mountain, and you look at it, and it is something similar to radio diagnosis, whereby you look at the organs and you find out what is in the organ, but you really don't know how the organ function. For example, within, say, liver, you may have a patient may have a cancer sitting in the liver, and if you do a radio diagnosis, you might find that the liver looks very, very similar. Every part of the liver looks exactly alike, and you may not be able to identify where the disease is. Whereas if you do a functional imaging, which is nuclear medicine related studies, you will find that different parts of the liver actually works differently, and you will be able to get a functional idea about, or a physiological idea about the organ itself. So they both have their own roles to play in radio diagnosis or in diagnostic imaging, but one is more focusing on the anatomy of the organ, whereas the other one is focusing more on the physiology of the organ. So the basic physics of radio diagnosis is the interaction of radiation with matter. As I said, the focus today is purely on photons, and when photon interact with matter, physics students and some of the basic science students would know that the three predominant phenomena that happen are photoelectric effect, Compton effect, and pair production. And we know that at relatively lower energy ranges, that is around 30 kiloelectron volt and below, the only phenomenon that exists is photoelectric effect. And above 30 keV, we know that Compton effect starts to take over. And then after 1.02 MeV, that is a threshold for pair production to happen. When the energy range becomes 1.02 MeV and higher, pair production starts to kick in, and then there is a share of photoelectric effect and Compton effect and pair production that can happen based on the statistical nature of the interaction. So based on the energy of the incoming spectrum and the property of the material through which the radiation pass, these three phenomena can happen, and it is a statistical phenomenon based on the cross-section of the material. So diagnostic imaging rely more on photoelectric effect and Compton effect, and you can see that there is a starking difference between the two, which is diagnostic imaging and radiation therapy. If you were to draw a comparison, you know that diagnostic imaging is used for diagnosis, whereas radiation therapy is for treatment. Diagnostic imaging uses kilovoltage X-ray. If it is an X-ray based imaging, it uses kilovoltage X-ray, whereas radiation therapy uses megavoltage X-ray, which is around the range of 6 to 20 MeV, whereas diagnostic imaging uses around 60 to 120 keV, which is the kilovoltage range. And some of the very common techniques used are X-ray machines, CT scanners. I'm sure you would have heard of all this terminology in your day-to-day life. Whereas in radiation therapy, the state-of-the-art device used and the most common technique used is using a device called a linear accelerator. And the basic physics behind diagnostic imaging is called differential absorption, which I'll come to what it is in a minute. Whereas in radiation therapy, what is expected is a biological change through a deposition of energy by the incoming radiation into the biological material, whereby the radiation, the high energy radiation that pass through the organs deposit the dose and ultimately results in the biological effect, which is the killing of the cancer cells. That is the aim of radiation therapy. Whereas in diagnostic imaging, we try and reduce the effect, biological effect. We do not want an alteration of the cells, but we rather want a differential absorption of the incoming X-ray by the organs of the body so that we get an image. We do not expect to have a biological change within the cell. Even though that happens as a side effect, that is not the aim of the procedure. So focusing more on the diagnostic imaging side, this is an X-ray tube, a cathode ray X-ray tube. You can see that is a cathode of the tube and that is the anode. And we know that electrons are accelerated using a high voltage. From the electrons emerge from a heated filament. By thermionic emission, you heat the filament and the electrons come out, and then you apply a voltage across the cathode and anode, and the electrons are accelerated towards the anode. When the electrons come and impinge the anode, they undergo something called a bremsstrahlung, or the sudden stoppage of the electrons, whereby the energy that was carried by the electrons are converted into photons, and thus X-ray is generated. You can see X-ray is produced when high-speed electrons hit the metal target, and that is what leads to the bremsstrahlung, which in German it actually mean by breaking radiation. Breaking, not as in break to B-R-E-A-K, it is actually B-R-A-K-I-N-G, which is break as like stop. So when the X-rays or the electrons stop at the anode, the energy is converted into radiation or into X-ray. And eventually it leads to something called a spectrum. And you can see that that is the bremsstrahlung spectrum. It is not monoenergetic. You can see for tungsten, which is one of the very common targets used, that is the characteristic X-ray, which the physics students would definitely be having a bit more understanding of what characteristic X-rays are. So bremsstrahlung as well as characteristic X-rays are produced in this phenomenon, and it leads to the production of a spectrum. So it is this spectrum that is used in diagnostic imaging. So low energy X-ray production, this is exactly what I have said, the same picture, and you can see focusing on this spectrum here, the relative number of photons versus the photon energy. You can see that when 100 kV, 100 kilovolt is the voltage or the potential difference between the cathode and the anode, the maximum energy of the photons generated is 100 keV, which means if there were electrons in this process, if there are electrons that has got 100 kilovolt or 100 keV energy, and if when in the process of them bombarding with the target, if they manage to transfer all their energy into X-ray, then those photons which are generated will have 100 keV energy, whereas not all electrons actually convert their energy into photons, and hence, depending on the amount of energy that is transferred by the electrons, there is a spectrum that is generated. So it is this spectrum or this photons that is used for imaging purpose. Then what is differential absorption? So you can see now if you put a material in the beam line or in the path of this X-ray, depending on the density of the material, they transmit the X-rays differently. It is more like if you were to have light coming from one end and if you were to put different material in the path of the light, the amount of light that is transmitted through different material differs based on the thickness and the density of the material. So it is a similar concept whereby you can see air passes most of the X-ray without any stoppage or without any absorption of the X-ray. There is only very, very, very little amount of X-ray that is absorbed by air. That is because in air, being gas, the atoms are sparsely populated, and the cross-section or the chance of interaction of atoms to the X-ray or to the photons is very, very limited. Hence, there is very little chance for the atoms to absorb the energy and hence reduce the intensity of the radiation. So air absorbs the X-rays very little, whereas fat absorbs it a little bit more, soft tissue absorbs it even more, bone absorbs it even more, and metals absorb most of the X-ray. But again, there are X-rays that can easily penetrate through metal. But if you were to look at the X-rays in the range of diagnostic imaging, which, as I said, somewhere around from, say, even up to 20 kV to around 120, 150 kV, in that range of X-rays, metal pretty much absorb all the X-ray. And this leads to, or this is what I call, or in scientific community, we call the differential absorption, whereby different material based on their density and other physical properties absorbs X-rays differently, which then, if a uniform fluence of X-rays were to enter into a subject, then depending on the material density of the subject, the exit X-ray or X-rays that comes out of the body is not the same as that went in. The one that comes out is having a differential fluence where as a result of the absorption or differential absorption by the different materials. And this is a classic example of a chest X-ray. So now looking into these two pictures side by side, I'm sure you will be able to tell me which one is which. So you can see the one in the red arrow has definitely absorbed a lot of radiation, and that is something closer to bone density. So you can see bone here, and that density looks very much like bone, whereas something that is a little bit less is more like a soft tissue here. Then that is the green arrow points to something soft tissue, which is more hard. And then you can see there is the fat deposition, which is the blue arrow, and what is lungs is the air cavity, which is in the purple arrow. That is what the air cavity is. So this is a classic example of 4 different densities or shades that comes out in a chest X-ray when X-rays pass through. So it is the differential absorption of X-ray by different material what leads to the production of an image. Then it is all about converting that fluence that comes out at the other end of the subject, converting that into a visible image is what is all left. So that is done by, in earlier days, that used to be done by using a photographic film, but modern day X-ray machines actually use a digital imaging technology. So that is the conversion of a digital an analog image to a digital image, and then we do not need to wait few hours or days before we actually get the image and a result of the examination. These days, the digital images appear instantly, and we might get a report within 30 minutes of the procedure being taken. So that is how advanced these imaging technology these days are. I'm keeping an eye on my time. I think I've got another half an hour left. So what we have seen just now is what we call projection radiography, whereby, as I said, in projectional radiography, there is an X-ray generator, which is a movable, which is mounted on a movable arm with all the electromechanical circuit that is connected to the arm, and the object or the subject that is being examined lie down or stand up on a couch, and then there is the X-ray detector that is right underneath the object, and then once the X-ray beam is turned on, it is usually turned on for for a millisecond, so or few milliseconds. So it's not like a long exposure, because as the exposure is long, it can lead to artifact in the image, which is more like a blurring of the image, which people deals with photography knows that very well. Even with a mobile phone, when we try and take a picture, if we keep it for too long, or if the object moves, then we know that there is a blurring of the image. And the same thing can happen here in projectional radiography as well. But the one thing that you need to be aware of is that this is called a projectional image, whereby we know that the object being examined is a 3D volume or is a three-dimensional object, but the image that we get is all squashed into a two-dimensional plane. So if we think of a chest X-ray, we know that there is heart and lungs and other organ in the beam path. Same with abdomen. If you image around or take an X-ray around your abdomen or a tummy, we have got quite a number of vital organs in there, which will be all in the image. They will all be squashed onto the one plane, and it is difficult to find out which organ is which unless you are an expert. So what I mean here is, when you do projectional radiography, the amount of information, the radiographical information that we get is limited, that you have to be mindful of. So this is a typical X-ray machine, as most of us would have been to an X-ray lab or an X-ray facility once in their lifetime and have seen this machine. Some common X-rays, even though I say it's common, it's very uncommon. This is a digitally generated X-ray. This is a very common X-ray. If you Google on, or if you go on internet and look for funny X-rays, you can see some of them. This is not as funny as it looks. This is an accident happened from a nail gun, and a number of nails actually penetrated through the skull of a human being, and you can see all the nail that is sitting inside the head. This is something what looks like when women wear high heel shoes. This is what happens to their leg. So this is the foot, and look how it stands up. This is an X-ray of a common organism, and this is a special X-ray technique whereby the X-ray unit actually goes around your face and take a more like a three-dimensional picture. It is not a full 3D. It actually puts images together and creates a 3D effect. So this is the image of which dentists use quite often to see the full picture of your teeth before any dental procedure is done. Now, as I said, a projectional radiography has got limited information, whereas how we get a little bit more three-dimensional information is using something called a computed axial tomography. It's called a CAT scan, but we shorten it to say CT scan. So it is a CT scan technology. What is the basis, or what is the use? A CT scan provides a 3D vision as opposed to a 2D vision by a conventional X-ray machine. And when I say 3D vision, it actually acquires axial slices. And this is the CT scan slice of a brain. And you can see it takes multiple slices. It is more like, the common analogy that I use is more like a slicing a loaf of bread. So you brought a bread from the market, and then you suspect that, it's been sitting there for a few days, and you want to know if there is any fungus that happened inside the bread, and is it still usable. So what you do normally is you take a knife and you slice the bread through, and finer the slices you make, then the better is the possibility of finding if there is anything wrong with the bread. So you slice it and look through individual slices, and those slices are what we call the axial slices in a CT scanner. Then when you put those slices back together, you actually get the full 3D picture of the bread. So it is the same concept. It is a very similar concept whereby the subject being examined goes through the CT machine, and the machine acquires CT slices. And you can see multiple slices acquired of the brain, and it gives a much better imaging facility, or a capability to identify anything wrong with the organ being examined. So this is the CT scan slice of abdomen, and you can see some of the organs very clearly. That is the liver sitting there, kidneys. I'm sure you will be able to recognize some of them. This is the vertebra. That's a spinal cord that's going through. So it's so easy even for a common man to go through CT slices and identify some of these. But the good thing is these axial slices can be then put together to generate other views, like a sagittal view and a coronal view. So this view that you see is what in medical terminology you call it a coronal slice or a coronal view, whereby it is more like slicing you from back to front or from front to back. And this is called a sagittal view. This is more like slicing the object from left to right or from right to left. So these views can be generated digitally, and that gives a very good picture of the subject being scanned. You can see that the spinal cord running through there clearly. That is the vertebra. So if there is any collapse of the vertebra, especially due to cancer, that is so easy to find out. So that is a good thing about having CT scans over conventional X-rays. So how it is done? It uses coupled source and detector technology. So what does that mean? This is a skin off or cover off of a CT scanner. And you can see that is again an X-ray unit and an X-ray tube that is mounted there. And that is an array of detectors that is there. So rest is all the electronics and cooling system and everything that is associated with it. You can see that is the heart. That is the X-ray tube with its collimation system and all that. And that is the imaging assembly or the detector assembly with, you can see all the fans that is used to cool the system down and all the electromechanical parts that are used behind to acquire and generate the image. So the good thing is the source, which is the X-ray tube, and the detector can spin around or rotate around the patient or the subject together. So that's why I call it a coupled source and detector. And then once it does it, what can happen is you can see when the patient or the person being examined lie down on the table, and the table actually is indexed, which means the table moves into the machine or out of the machine in a stipulated manner, in a particular manner, step by step. And then after every indexing, the coupled source and detector spin around the patient once, and then the table moves again, and it spin again, and then table moves, spins. So it is like spinning of the source and detector and movement of the table. So it is done sequentially. So this is one of the early technologies, but these days you don't need to spin and then index and spin and index. You can sort of do it together to acquire the image. So, but anyway, in a simple way or in a simple sense, it is once you spin the source and detector, and then you get one slice, and then you move the table, then the system spin again, and then you get the next slice. So the CT scanner acquire the image slice by slice. So in every revolution, it acquire one slice. That is, as I said, that is the early technology. And depending on the slice or the collimator or the opening of the X-ray source, the slice thickness can be adjusted. You can do like a 1 millimeter slice or a 10 millimeter slice or a 5 millimeter slice. So that's all, those are all things can be set before the scan is done. And even after the scan is done, post-processing of the image can be done in order to change the slice thickness. So that's all available technology. As I said, it's to some extent is based on the source or detector collimation is what decides the slice thickness. So just looking at the collimation. So this is the pre-patient collimation. That is the source, and that is the pre-patient collimation. You can actually move these collimators that is shown in the green blocks. You can move it in and out, and based on where it is, as it comes in, the slice thickness decreases. As it goes out, the slice thickness increases. And that's the patient there that's being examined. And you can even do a post-patient collimation. That is a detector there that is just before the X-ray gets to the detector, you can increase or decrease. That can adjust the slice thickness. And then you get an image, an analog image using an analog to digital converter that can be converted into a visible image. Helical CT scanning doesn't use one full revolution to acquire one slice. It actually uses partial revolution to acquire one slice. The advantage is you can actually acquire images faster, and helical CT scanning technology is the state of the art in all modern day CT scanners. So instead of using a single detector, you can see that is a single detector that is used. It uses multiple small detectors. And then that allows, that along with the helical technology, allows you to acquire images really fast, which has got an extremely high advantage in, especially in CT scanning organs that have got involuntary movement within the body, like the lungs and the heart and all that. Even there are organs that moves involuntarily within the abdomen. So in order to image those organs, fast imaging is helpful, because faster the imaging, less is the artifact or blurring of the images. You get a high amount of information or a great signal to noise ratio when imaging becomes faster. So helical scanning technology is actually one of the advanced technology that is used in CT scanning. You can see, so this is a GIF of the how the image would look like once a scan is done, and you can see how a post-processed image looks like. That's the image of the heart. And these were things that we couldn't think of maybe 30-40 years ago, when around 1970s, when CT scanners were first invented. And the two scientists who invented the CT scanner actually got Nobel Prize in medicine. So not in physics, but they actually got their Nobel Prize in medicine. That tells you how important this technology is in modern day medicine. But the one thing that you have to be mindful of is the amount of radiation dose that the person gets, because these are people who may or may not have disease. By using radiation, it can actually lead to some, there is a really low possibility of radiation induced cancers in subjects that are undergoing these sort of procedures. That is why there is a philosophy, general philosophy of using radiation devices in imaging. It is the justification of the practice. If you can achieve the same image quality and clinical information can be derived without using radiation, then those technology should be used. For example, if you can use MRI or ultrasound scanning to get the same clinical information, then you should not use X-ray or CT scanners. That is justification of the practice. And then if a particular subject needs CT scanning, then the practice must be optimized, whereby the best technology and best practices should be used in clinic to acquire the image. That is what we call the optimization of the use of radiation. So these are some of the typical values of effective dose for various medical X-ray use. You can see a whole body CT has got around 10.6 millisievert. That is a unit of effective dose. And cardiac angiography is less. Lower gastro, I don't want to be spending a lot of time going through each and every one. You can see dental X-rays and dental ortho pantomogram that I showed you before, which was the picture of the entire jaw and teeth. It's really low compared to a cervical spine or a head CT scan. This is sort of the range of doses that the subject receives while undergoing such procedure. Now, as I've gone through almost bulk of my time, I will now move on to, so these are the two most common radio diagnostic procedures that we use in our daily life. Now, moving to nuclear medicine, as you can see, this compared to radio diagnosis, this is a very unclear medicine. At least when I was a student, this was a bit of a confusing topic. But with some of the guidelines from or teaching from some of the great eminent professors from BARC. This is one of the fascinating fields of medicine that or use of radiation that I've seen. The amount of clinical information that you can derive from using nuclear medicine is phenomenal. You can see it's a medical specialty that uses the application of radioactive substances in the diagnosis and treatment. But today I will focus only on the diagnostic part. Some of the very common procedures used are bone scanning, PET scanning, SPECT scanning, cardiovascular imaging, renal imaging. So there are quite a number of nuclear medicine procedures that we use on a day-to-day basis. So what it does is small amounts of radioactive material is used to diagnose, evaluate, and treat. So it uses radioactive material that goes into the body. So clearly the first difference is a radio diagnostic procedure using an X-ray machine. The source of radiation sits outside the person. So you have an X-ray source that is outside the person, and X-ray comes into. Whereas in nuclear medicine, small amounts of radioactive material is actually administered into the person being examined, and that person act as the source of radiation, and then detectors are around that person detecting the radiation coming out of the person, and images are developed based on that. The most common radioactive material used, the workhorse of nuclear medicine, is technetium-99m, the isotope 99m of technetium. Around 40 million procedures are performed every year around the world, out of which actually is about 80% of the total nuclear medicine procedures that is done. So you can see how important technetium-99m is in the field of nuclear medicine. So radioactive tracers, which are called radiopharmaceuticals, are used to assess the bodily functions. You can see it is not interested in the body anatomy, it is more in the functioning of the body. Some of the techniques used is with technetium-99m. Technetium-99m is a radioactive tracer, but when it is mixed with or tagged with certain other chemicals which the body can absorb, it is called a radiopharmaceutical. So radiopharmaceutical is what is administered into the body, whereas radioactive tracer is the core radioactive material. The pharmaceutical is actually made from the radioactive tracer that is administered into the body. You can see the pertecnate ion of technetium is used for bone and thyroid scanning. Hexametazine complex of technetium is used. It has got a property of breaking the blood-brain barrier, because we know that there is a huge barrier between the rest of the body and the brain called the blood-brain barrier, whereby brain doesn't allow toxic substance to get into the brain, and using its mechanism called the blood-brain barrier. But in order to scan the functioning of the brain, this hexametazine complex of technetium has the ability to break the blood-brain barrier and get into the brain, which helps in imaging brain. Sestamib is another radiopharmaceutical used for myocardial perfusion imaging, which is imaging the heart and the ability of the heart muscles to function. And mercaptoacetyl triglycine is another ligand that is used for renal imaging, which is imaging the kidneys. So these are some of the very common procedures used in nuclear medicine using technetium-99m. So to give a bit of a detail of how it works, first is the production of radioisotopes. So most of these radioisotopes used in nuclear medicine are not naturally occurring. They have to be manufactured either in a nuclear reactor, like this one in leukocytes in Sydney, which provides about 25% of the global demand of nuclear medicine isotopes are met by this reactor in Sydney, or by using something called a medical cyclotron, which is not as big a device as a nuclear reactor is. This can be mounted or can be housed inside a hospital itself, and there are many hospitals in and around the world which does that. In physics, we know cyclotrons have got a central portion which has got two Ds and electromagnetics on magnets on either sides. When the particle source, a charged particle, is left in the middle or in between the two Ds, and when magnetic field is applied, on a charged particle, we know it takes a circular path. It goes in circles, and as it moves in circle, it keeps acquiring the energy, and when it comes out with high energy, it is bombarded with a target. So when the particle like proton comes out and hits with a suitable target, that leads to a nuclear reaction that is leading to the production of suitable isotope. So this is the basis of a medical cyclotron. So once these radioisotopes are generated, the reason why it has to be in some of the closer to the medical facility where the scanning is done is because these are quite a number of these isotopes are short half-life. The technetium-99m has got only 6 hours of half-life. Fluorine-18, which is another very common isotope used in PET scanning, has got only 120 minutes, which is just over 2 hours of half-life. So half-life being really low for these radioisotopes, they have to be very close to where the imaging procedure is done. So once the radioisotope gets to a place called the hot lab, you can see from the cyclotron room, the radioisotope is pushed into the hot lab, where it generates the radiopharmaceutical, and that is using the auto dispenser, and the quality control is all done, and then that is pushed into the treatment room. So from cyclotron, the radioisotope comes from the hot cell, it is converted into the radiopharmaceutical, and then it is given to the treatment room or to the imaging room. So administration of the radiopharmaceutical happens, and then this is done either intravenously or orally, and then the subject waits for a biodistribution to form. So this particular material, along with the radioisotope or the radiopharmaceutical, the speciality is that the material that is tagged with has got properties whereby it will be selectively absorbed in different organs of the body. So as I said, technetium-99m, when it is tagged with different materials, it targets different organs. You can see it can target bone, it can target thyroid, it can target heart, it can target kidneys. So based on what is the tagging agent used, it goes into different organs of the body, and after a while, waiting for maybe 30 minutes or so, depending on the tracer used, it generates a biodistribution within the body, and then the subject becomes the radiation source. So this is how what happens when a particular radioactive tracer is injected or administered into the body. In 10 minutes, this is what happens. In 30 minutes, so you can see the biodistribution changes as time passes. And then imaging is done, which is collecting and processing of the radiation data that comes out of the body. So you can see that this is what is called a gamma camera, whereby it detects the gamma photons. So technetium-99m emits gamma photons of 140 keV, and these detectors that is sitting at 90 degrees to each other has got detectors that can pick up the 140 keV gamma that comes out of the patient's body, and that ultimately generates the image. So those X-rays that comes out are collimated, and that you can see that is a sodium iodide crystal that is acting as the detector of the gamma photons, that is then fed to photomultiplier tubes, which then is fed into the computer that is generating the image. So once that imaging is completed, the person that has undergone the examination waits for the decay or flushing out of the radioactive material from the body. We know that radioactive materials have got a physical decay based on their half-life, and then there is a biological decay as well, which is either the material will be absorbed within the body, or it will be flushed out through our fecal matter or through urine or sweat or any of these, and that comes out of the body. So when you look at that, the amount of isotope comes or decreases as time passes. You can see that is a biological decay curve, which is in red. The radioactive decay curve is in purple, and then there is the effective half-life or the effective decay, which is the combination of the radioactive decay and the biological decay. So the physical decay plus biological decay leads to the effective decay, which helps in the removal of the isotope from the body once the imaging procedure is completed. Whereas in therapy, we do not expect the isotope to be flushed out of the body quickly, because we want that isotope to be absorbed by the particular organ having cancer, and then we want it to treat. So that is the aim. Whereas in imaging, we want, as soon as the imaging is completed, we want the isotope to be flushed out of the body to reduce the dose to the body. Some of the common procedures used are bone scan. That is a very simple scan whereby usually technetium-99m is administered, and a gamma camera is used to create something called a bone scan image. You can see what is in black spots here are all where the radioisotope went. So some of the absorption is very common. You can see in and around this region where the heart is, there is more absorption, because as we know, there is a lot of blood that is going in and coming out of the heart. So there will be a lot of radioactive isotope in the heart region, in the bladder region because of urine collection. Whereas there are some uncommon areas you can see around the rib region here. That is not a very common area where you would find the radioactive isotope uptake. So if you find uptake in uncommon areas, that could be due to the presence of a cancer cell, because cancer cells are hyperactive and they take up a lot of blood and glucose and all that for their growth. So along with the blood that is being pumped into the cell, the radioactive isotope goes into the cell, and that leads to the collection of radioactive isotope in there. And this is a patient having metastatic bone cancer from a prostate cancer. So he initially had prostate cancer, and then that spread into bone, and eventually leading into the cancer being spread into the thorax and the ribs region, you can see. So another common technique is a single photon emission computer tomography. So this is called a SPECT scan. It is slightly different because bone scan is more like a projectional radiography. It gives you a squashed projected image, just like our X-ray, but this is more functional. Whereas a SPECT scan is more like, that is why it is called a computer tomography. It is a three-dimensional imaging, and it uses a dual gamma camera, and the gamma camera system actually can spin around the subject being examined. And it uses the same technique, but it comes up with a three-dimensional image, which is an axial slice, and you can go through slice by slice and see what is going on. The other most common technique is called a positron emission tomography, PET scanning, which uses, this is a total body PET scanner. So the physics behind positron emission tomography is that the subject being examined will be administered with something called fluorine 18. It is a positron emitter. So fluorine 18 is a radioactive material. Then that is tagged with deoxyglucose to form what is called the FDG, fluorodeoxyglucose. It has got glucose in it. So once that is administered into the body, every cell loves glucose. So the cells that are more active needs more glucose, and hence all the cells in the body that is hyperactive actually absorbs the fluorodeoxyglucose. And then the fluorine 18, once it gets to the cell, the fluorine 18 starts to emit positrons. And when we know that positron is the counterparticle of electron, whereby it has got the same amount of charge and mass of that of an electron, but it is positive in nature. So there is a classic case when a positron combines with an electron being antiparticles, the mass of the positron and mass of electron converts into energy as per E equal to mc square, as per the Einstein's famous equation. So mass is converted into energy. So the rest mass of positron and rest mass of electron is converted into energy. And we know that the total rest mass is 1.02 MeV. So it eventually becomes a pair of 511 keV gamma ray. So at the end, what happened is within the cell, a positron and an electron annihilate. It leads to pair annihilation and the production of two gamma rays, each having energy 511 keV, and they will be emitted in 180-degree direction. And then that is detected. Those 511 keV photons are detected by special detectors, and it is converted into image, leading to positron emission tomographic images. The advantage is this is highly effective in cancer imaging because we know cancer cells are hyperactive and they selectively absorb the FDG or the fluorodeoxyglucose. And hence, this is very, very, very sensitive to cancer imaging or cancer cells. And we can pick up cancer cells way more than what CT scans and MRI scans can. So this is how a PET image will look like depending on the material that you have taken or depending on different chemical that people use. So if you use caffeine, this is how your brain look. If you take other medications, you can see the amount of glucose that goes into the body changes. And this is a classic example of how the uptake is different based on how your brain works. And this is how the brain works depending on your habit. These are all PET images. You can see between a non-smoker and a smoker, in a smoker's brain, the blood flow is actually less. Between an alcoholic and a normal person, you can see. Between an obese and a normal person, between someone who has been in the influence of cocaine and a normal. So this is not just for oncology. This can be used for brain function studies as well. Hence, I said this is more to do with functional imaging. I'm almost towards the end of my talk. Other very, very common and interesting technique is myocardial perfusion scan, which study the blood flow through the heart muscle. And this is whereby the subject being examined will be on a machine like a treadmill, and then they will have System B, the radioactive radiopharmaceutical administered into their body, and then myocardial perfusion scan is done, which is more the imaging of the heart to see how the blood flow is inside the heart. And this will help in identifying a possible heart attack or how the cells work after a heart attack has happened, if there is any potential for a subsequent heart attack to happen. So these are all some of the very common imaging technology used. And you can see these are some of the, this is what happens when the heart is normal. This is how the blood flow. This is an abnormal heart in different axes, you can see. So the blood flow is clearly different in an abnormal heart compared to a normal heart. So this gives a good indication of the health of the heart and a potential myocardial infarction. We use image fusion to better understand. As I said, CT and X-rays and MRI scans all give anatomical imaging, whereas nuclear medicine provides more of a functional imaging. But if we fuse the images, we get a much better idea, because nuclear medicine scans doesn't give any indication of the anatomy. It just gives about indications of the functional aspect of the organ. So when we fuse the images together, you can see that's a CT image, that is a PET image, and that's a PET CT image. So this is a PET CT image, and that's a PET only image. When you fuse them together, functionally and anatomically, you can find out what is happening in the brain and where is happening in the brain. That is an MR image, and that is a PET image. When you fuse them together, you get an MR PET. You can do MR PET, you can do CT PET, you can do MR CT PET. So all sorts of image fusion is possible. That gives an extremely good clinical indication of what's happening with different parts of the body. But this does not come for free. It is at the expense of some radiation dose. If you are not careful, when I say you, not the person being examined, the people who are the professionals who are working in this area, is if they are not careful about the use of the technology, then that can lead to very hazardous effects. Something like, we actually want this. Like, this is the X-ray image, CT image, MRI image. This is an angiogram. This is PET scan. You can see all this. This is all really good, but It should not be at the expense of this. This is what happens if you're not careful, and if excessive radiation gets into the body, it can lead to damaging effects. So we don't want what is in the green box. We rather want what is in the red box. And with that, thank you so much. I think I have taken few extra minutes. Apologies. And that's all from me for today. Thank you.
Yeah, thank you, sir. Thank you so much, sir. Now,
Hello.
yeah, fine, sir. Now, hello,
Do you want
sir.
me
Can
to
you hear
stop
me?
sharing the screen? Yeah, I can hear you.
Yeah, can you answer a few questions, sir?
Oh, yeah,
Yeah,
clear.
yeah, yeah.
Oh, for sure. So Kishore Poria has asked me a question on CT scan gives only image or damage of bone only, or tissue damage also. As I said before, CT scans can provide a comprehensive image of bone as well as normal tissue. So as I alluded to in the session, you can see that when X-rays, planar X-rays are used, it actually gives a good contrast for the bone, and soft tissue contrast is actually very, very low. You cannot see all the other normal organ very clearly. You can to some extent, but not as much as the CT scans give. CT scans are axial slices, which gives a good indication of bony anatomy, including like the spine and all the ribs and all that. And if you're doing around the pelvic region, it gives you a good indication of your femur, the pelvic bone, the leg bone, and the whole pelvic anatomy. It gives a good indication, but not just the bone. It can show you everything, all the organ that is in the pelvis region. So yes, it can provide clear image of the normal tissue, and as well as if there is any tissue damage. But as I said, it is limited. That is why functional imaging, like nuclear medicine imaging, is helpful in better understanding what is happening with the functioning of these organs. So difference between CT scan and MRI scan. Yeah, that's a really good question from a simple point of view. CT scans use radiation, whereas MRI scans do not use radiation. It instead use the magnetic resonance imaging technique. So it is the magnetic resonance property of materials within the body, especially the hydrogen that is in the body, is utilized in coming up with MRI scans. So the advantage is with MRI scan, things like or organs like brain can be imaged with a very, very, very good contrast. You can see a much better picture of the brain or other organs in the body using MRI scans than CT scans. So MRI images are actually better quality image than CT images, and they do not have radiation risk, which CT scans do have. So that is the basic, very fundamental difference between the two scanning technique. Divya Raja has asked another question: is the scanning instruments harmful to our health? Say, as I said, every precaution is taken before such procedures are done in medical facility. There are, from the time these equipment is manufactured to when it is installed in hospitals or scanning centers, and for day-to-day procedures, there are strict protocols and guidelines to reduce the dose and radiation damage. So in medicine, what we always look for is the comparison between risk versus advantage. So if by taking a very, very small risk of having a very, very low radiation dose, for example, someone present to the hospital with a possible fracture of the bone, someone fell down and thinks that the bone could be fractured, the patient is in real pain. Would you actually want to be undergoing a CT scan or an X-ray to see what exactly happened and undergo a surgery and fix it, or worried about the radiation dose and not to do any procedure and end up in complication. So the practice should be justified, whereby the clinical benefit should always be higher than the risk. Then only we do the procedure. What is the time duration between one CT and another? You mean for the same? I understand. Tamil Selvi has asked the question. I understand the question is for the same person, how long you should wait before 2 CT scans are done. Actually, the amount of radiation dose in a CT scan is actually very low. It is not as high as we think, or we think in terms of radiation treatment for cancers. It's an extremely high dose compared to the scanning dose or the imaging dose. So again, a CT scan was done today, and the radiologist or the doctor who looks through the images have got some doubt, and the patient is in some pain or is in some complicated condition, or have to have a repeat scan tomorrow or on the same day, it doesn't matter. We do rescan our patients quite often to get a better understanding of what's happening. So 2 scans on a day is not a big deal, but that doesn't mean you want to go and do 2 scans every day for a week. No, that is probably not quite beneficial, but a couple of scans a day is okay.
Yeah, fine, sir. This will be the last question, sir.
Okay, yeah. So there is another question from Lalan Kumar Yadav. Ask, MRI gives only anatomy information or physiology as well? So conventional MRI provides anatomy only, but there are new technology which is called the functional MRI. They can provide functional imaging or physiological imaging as well. So yes, modern day technology actually gives indication of the brain functioning or function of the organ. Yes.
Thank you, sir. I call upon Mr. Khalil Mohammed Ibrahim to give vote of thanks.
Thank
All
you,
right.
sir.
Thank you.
Good morning to everyone. I am honored to have the opportunity to give a vote of thanks on the end of successful webinar. On behalf of the Department of Science, St. Joseph Engineering College, I take this opportunity to deliver the vote of thanks. First and foremost, we would like to express my profound gratitude and very special thanks to our most respectful chairman, Dr. B. Babu Manoran, St. Joseph Group of Institution for his constant encouragement and providing a inspiring environment for such educational developments. I would like to express my deepest appreciation and sincere gratitude to Mrs. B. Jesipriya Madam, Managing Director, and Mr. B. Sasisego, Sir, Director, Dr. Vaddi Sesagiri Rao, Principal Dr. B. Parvadavartini, Dean, for their support towards this event. At the outset, I thank our chief guest and resource person, Dr. M.C. Mahesh, who has readily accepted our invitation in spite of his busy schedule and enlightened the session with his excellent presentation, making this seminar more interesting and meaningful. I am sure that due to his contribution in his specialized area, the purpose of the webinar has been fulfilled. Thank you, sir, for your very interesting thought provoking address. I would like to express our profound gratitude to our head of the department and convener of this webinar, Dr. V.N. Nandini Devi, who has been deriving force behind this whole process in all the phases of this webinar. I am very happy to express my grateful thanks to all the participants from different parts of the world for their dedicated positive response to our invitation and distinct participation, as no program can become successful with a single person. So I extend my big thanks to my department colleagues for their support, timely help, and cordial cooperation. I would like to thank you again for making this event a grand success. Thank you all. Thank you, sir.
Thank you all. Yeah, in this session,